Yeah, hi everyone, and welcome. It's really great to see so many people interested in the topic. I'm Laura, and I'm here to talk about my thesis research, which has explored ADHD, trauma, identity, and well-being. So, on the agenda for today, I'm going to introduce you to the other people that completed the research with me. It wasn't all just me, and introduce a few key terms that I think will be really helpful for people to be aware of as before I really get into things. Give you a bit of background to the research, talk you through what we did, what we found, and spend some time thinking about, based on the kind of findings of the research, how we can best support people with, well, ADHDers with co-occurring trauma. And then I'll give you a little overview of kind of the conclusions I've drawn and my ideas for future research, kind of based on the findings. And then, yeah, we will have time for discussion and questions at the end. And yeah, I have scheduled in a couple of breaks. I'm just mindful of the irony of me talking for an hour about ADHD. So yeah, there are some breaks in there, but obviously please do just feel free to get up and wander around and go to the loo, make a cup of tea as you need to. Don't feel like you have to be tied into them. So as a bit of background about me, I'm a trainee clinical psychologist in my third year. This was my thesis project. I'm currently working clinically with people that have experienced severe and multiple disadvantage, and ADHD and trauma are really kind of common in that population. And I have ADHD myself. Dr. Anna Tickle was my research supervisor, my main supervisor. She works clinically with people who've experienced SMD and has done for a long time. She's a senior research tutor at University of Nottingham. There was also Thomas Schroeder as another supervisor, and Dr. Fleur Michelle Coffey, who's a consultant psychologist who works clinically with autistic people and ADHDers and also has lived experience of ADHD. So what is ADHD? I'm not going to spend too long on this. I'm trying to explain sort of the real detail of it because it's not too much the focus of the presentation, but just to give a kind of slight overview, it's a neurodevelopmental condition associated with inattention, hyperactivity, and impulsivity, if you want to go right back to the diagnostic guidelines. I wanted to highlight that the evidence base is quite polarized regarding the cause of ADHD. And this will become kind of more relevant to reflect on as the presentation goes on. But essentially, the polarization is on one side, the medical lens, the way you view kind of ADHD would be considering it to be an illness with symptoms that can be treated. And then more kind of on the other end of the spectrum is the psychological lens, which might consider ADHD to be another way that systems of power pathologize normal experiences. And then you also have kind of the view that I think anecdotally most of the community would probably take that ADHD actually isn't really either of those things. It's more of an intrinsic difference, and that's certainly the view that I take. And in this study, that's how we've conceptualized ADHD, as being an intrinsic kind of individual difference, not a psychiatric label, even though it does exist in the DSM. And conceptualize the problems that ADHD causes as being socially constructed. So that's a little bit, I know that feels contradictory. So it's essentially me saying ADHD is real. However, the world we live in is not set up for neurodiversity, and therefore that causes problems for people. So what is trauma? So I've deliberately kept the term trauma really broad for this study and used the definition that is taken in national kind of trauma-informed best practice guidance. So defining trauma as an event, series of events or set of circumstances that is experienced by an individual as harmful or life-threatening. And deliberately kind of use that broad term to recognise that not everyone who has experienced trauma will go on to develop PTSD, post-traumatic stress disorder, but they may still experience long-standing adverse effects in relation to their mental health, well-being, and ability to function. And then lastly, there's a lot of introducing terms, but I think this is the last one. So how I'm defining identity in this study. So we explored something called narrative identity, which is essentially the way a person constructs their story about themselves internally, so thinking about past events, how they interpret the present, how they imagine the future, all of that comes together in a kind of story that people tell about themselves, and that is narrative identity. And I've used a specific model to kind of conceptualize this, which I'm not going to go through with you because I think it is a bit jargony, but three kind of aspects of narrative identity that it might be helpful for you to hold in mind as we go through are meaning making, which is kind of people's ability to make sense of their experiences, agency, which is are people's sense of control over their life experiences, and communion, which is the perceived quality and quantity of people's relationships. And those three I've pulled out as being important to hold in mind because they've all been associated with higher well-being in existing research. So, as a bit of background to why this study was needed, well, why I felt it was needed. In terms of prevalence, ADHD is estimated to occur in 3 to 40% of adults in the UK, and in over 40% of autistic adults. There's a massive kind of comorbidity there with autism. Trauma-wise, if we're taking that broad view of trauma, globally estimated to exist in over kind of 70% of people, or 70% of people are estimated to experience trauma in their lifetimes. In England, that percentage is a little lower at around sort of 35%. And I think the kind of obvious reasons for that are we don't live in a country where there's, for example, like an active war kind of going on within the country. So you do have kind of quite a lot of variability globally. And within England, about 6% of people meet the screening criteria for PTSD. So with ADHD and trauma together, it's quite difficult to pin down sort of an exact stat because so many people have experienced a traumatic event, but there won't necessarily be data on that. And we do know that people with ADHD or autism are more vulnerable to exploitation, to various types of abuse. So we know that it's likely that people with ADHD or autism are going to have experienced kind of a traumatic event, and possibly more likely than the general population. And we do have a very recent international review that has started to put some actual data around prevalence in relation to ADHD and PTSD co-occurring. We don't have the same data available, unfortunately, for autism, but hopefully in the not too distant future, that gap we filled a little bit as well. But this study found that PTSD co-occurred in 36% of adults with ADHD, which obviously that's quite a high percentage. So yeah, in terms of prevalence data, we've got an idea that actually there might be quite a lot of people out there with co-occurring ADHD and trauma. But the challenge is clinically, the co-occurrence of ADHD and trauma isn't really recognised in NICE guidance, in NHS ADHD guidance, in diagnostic criteria. It's just sort of not really discussed as a comorbidity at all. And that becomes a challenge because treatments for ADHD or PTSD or trauma are very different. For ADHD, it's sort of medications, like stimulant medication is the first line kind of treatment, whereas for trauma, that would obviously be something very different, sort of mental health support, EMDR, that kind of thing. And the services that provide those different kinds of support are completely separate. They've been very much siloed. So ADHD and autism diagnosis services are entirely separate from primary care, from mental health services, which it kind of exacerbates the problem in a way where people do have sort of needs that, where you need support from ADHD services and mental health services. It doesn't help that those services are quite separate and don't always talk to each other as well as they could, like many NHS services. So all of this could make it quite tricky to navigate for people, for adults with ADHD and co-occurring trauma. And there's a lot of kind of evidence out there of these pathways being quite fragmented, delays occurring in people's care. That kind of already is known, sort of, for pathways to ADHD or pathways to trauma support individually. So there was kind of an assumption I was making that actually when you're combining both of these concerns, it's potentially going to be even more tricky to navigate. Another challenge is that actually when ADHD and trauma co-occur, their presentations can overlap a lot, can look very similar, again, can create quite complex clinical presentations. And overshadowing can occur a lot. Either when ADHD is focused on at the expense of trauma, when trauma is focused on at the expense of ADHD, or when anxiety and depression is focused on at the expense of everything else. Trauma symptoms like hyperarousal and avoidance can mask ADHD traits relating to kind of sensory overwhelm. ADHD traits like inattention, hyperactivity could overshadow trauma-related symptoms like dissociation or hypervigilance. So it can be quite challenging to pick those things apart. So how does this all kind of tie into identity? So both unrecognised ADHD and unrecognised trauma have been shown to influence a person's ability to make sense of their experience. And if we go back to those aspects of narrative identity that I highlighted as being kind of important for well-being, we know that meaning making is a part of narrative identity that's associated with well-being. So potentially when that's disrupted, it would make sense that well-being would suffer as well. And it's well known as quite a large evidence base for both unrecognised ADHD and unrecognised trauma in terms of people telling stories about themselves that reflect high self-criticism, blame, low self-esteem, and that's also associated with poor well-being. So what we did. So because of kind of all of these existing challenges, and the fact that ADHD and trauma has been discussed in the literature for a long time in terms of like diagnostic confusion or people considering that, is it ADHD or is it all just trauma? Like those conversations have been happening for quite a while, but actually the idea of ADHD and trauma coexisting that's not really covered a huge amount in the literature at all. It's only really started to be explored quite recently in the international review I spoke about and a few other studies. And we thought about how the process of seeking support for ADHD and trauma could provide an individual with an opportunity to repair identity disruptions. So in existing literature, the process of getting a diagnosis is often referred to as kind of a key turning point in terms of ADHD and identity. And for trauma, similar kind of experience, except a lot of people with trauma don't end up with a diagnosis, but that kind of point where it's recognised again becomes a really kind of key turning point in identity. So the process of seeking support has the potential to be really impactful. However, we know we've got a lot of challenges with kind of the siloing of different support pathways, stigma existing within services, delays, wait lists, all of that. So how is this potentially going to be impacting on identity, the ability to repair that kind of damage that's already existing? So we set out to capture self-reported participant accounts or stories, as we're calling them in the study, to understand people's experiences of accessing support for both ADHD and trauma and how these experiences influenced narrative identity and well-being. And we also wanted to highlight the specific needs and challenges faced by this population and contribute to a broader understanding of how to effectively support individuals with co-occurring ADHD and trauma. So as a kind of overview of what we did, what the study involved, we included people who were diagnosed with ADHD as an adult and people who'd experienced trauma. We did require the diagnosis for ADHD just because I really wanted to explore the process of seeking that diagnosis, because that is known to be such kind of a pivotal turning point in relation to identity. It felt like a really kind of interesting thing to explore. I am mindful that this potentially excluded a lot of people that are on wait lists, and I spent a lot of time wondering about that, but I think because it felt so important to explore like the before and after in relation to diagnosis, that was kind of why we kept that in there. But with trauma, didn't require there to be a PTSD diagnosis because just so many people that have experienced trauma don't go on to develop PTSD. The gaining a diagnosis wasn't as pivotal in terms of identity kind of repair for trauma. It was more just about the recognition of it having happened, as opposed to a diagnosis being really, really impactful in that sense. So for this study, we actually recruited from a pool of volunteers that had taken part in a previous study that I'd run, and they'd volunteered to be part of future research. So in the end, 13 adults completed interviews over Teams. Actually, one of them did it over email as a reasonable adjustment, but typically those interviews went for about an hour in length. And we explored the data using something called narrative analysis, which essentially meant that I was looking for patterns in the stories that people told about themselves. And when we're talking about stories, I mean tales that people tell about themselves to help them understand the world and to inform their view of themselves, their understanding of the world around them. So looking for patterns in stories, looking for patterns in the narrative resources people used. And by narrative resource, I mean the resources people use to construct their stories. So that might be things like culture, family, peers, health services. Those are all kind of things that will inform the stories that people tell about themselves. And I was looking to identify these patterns, build themes and an overarching kind of story, if possible, like a cumulative story of all of the participants. I was also holding in mind those aspects of narrative identity that we touched on earlier. So meaning making, agency, communion, keeping those in mind while looking for the patterns in stories. So in terms of participant demographics, we had mostly female, so 9 identified as female, 2 as male, 1 as agender, and 1 as transmasc non-binary. Everyone was aged between 26 and 57, so sort of average age of 38. Mostly white participants, 1 identified as white Chinese and 1 other identified as Middle Eastern origin. And almost everyone had additional mental health diagnoses, most commonly anxiety and depression. So I'm going to hold our break for a minute because I think we'll probably take a break more around past, I think. Otherwise, it seems a little bit soon. So hold that thought and I'll take it in a little bit. So this is a kind of overarching story that put together. So I appreciate there's a lot going on this slide. So I'll talk you through it a little bit now. We're then going to talk through all the different themes and we'll come back to this overarching story because I think it might make a little bit more sense once we've had a chance to talk through it a little bit. But essentially looking at this slide, so these sections in the middle, so making sense of shame, those kind of slightly more circular boxes, they're the themes identified. And they're in something of a chronological order. So starting on the left-hand side, where people have sort of more poor well-being, you've got that first theme around making sense of shame. And then as you gradually move along people's stories, that's where these different themes come into play. And as you move kind of from left to right, you're seeing well-being get a little bit better. In these sort of navy rectangular boxes, they are narrative resources. So, for example, on the left-hand side, It's Your Fault was a story a lot of people were given by peers, by family, and that became a narrative resource that shaped stories of shame, for example. You've got the naming of ADHD or trauma. That's a really powerful narrative resource for a lot of people. And then in the boxes immediately below, those are the kind of stories that were generated because of the narrative resources. So, for example, the naming of ADHD or trauma generated stories of acceptance of survival. Whereas if we go down to the bottom, the absence of ADHD and trauma-informed care generated stories of powerlessness, of being failed by the NHS. But I won't go into too much detail with that now because we are going to talk through the themes individually and come back to this, which I think will then tie things together a little bit more. So the first theme, chronologically speaking, was making sense of shame, which shame was something that just all of the participants had experienced. And at the beginning of their stories, people often drew on narratives held by their peers and their family to make sense of their experiences, and typically learned that their thoughts and behaviours were different from what their peers and families perceived to be normal. Many felt that their struggles in social situations were their fault and something to be ashamed of. So on all of these slides, I've included some participant quotes. I'm not going to read them all out to you. You'll have access to the slides or the webinar afterwards if you want to go through and read them all in a bit more detail. There might be a couple that I'll pull out, but otherwise we'll probably be here all day if I read them all out to you. Where people had experienced trauma during childhood, they'd often been given explicit narratives of blame and of other people's anger being their fault. People often describe their concerns being dismissed and how everything gets labelled as anxiety and depression. Therapy was typically unsuccessful and led to further feelings of shame. And stories of healthcare services not helping or therapy not working. Stories of shame really profoundly shaped how people interacted with health services for years to come sometimes, and often delayed people's access to appropriate support. ADHD diagnosis, or the naming of trauma, then provided new narratives for most people. So allowing new stories of acceptance and understanding, which began to replace feelings of shame. These new narratives allowed everyone to reflect on their lives through different lens, and often consider, for people, for example, getting an ADHD diagnosis, seeing their lives through a different lens, they may then also consider, oh, actually, maybe these other things that happened to me weren't my fault either, and then potentially went and pursued mental health support or trauma support, and vice versa. There wasn't really a common story of ADHD being diagnosed first or trauma being recognised first. It was a mixed bag for most people, but for everyone, whichever was recognised first, that new lens allowed people to consider that, oh, perhaps everything wasn't my fault and these other things might not be my fault too. So as we move along chronologically, the next theme that comes up was proud survivors and protectors. There was typically a shift in the sense of control participants had over their lives following an ADHD diagnosis or awareness of trauma, moving from feeling really powerless to then understanding what support they needed to seek. And at this stage, many participants drew on narrative resources like support groups, online forums, and websites. They commented on improved well-being in the context of finding community. Almost everyone developed stories about being a survivor, which often led to further feelings of empowerment, of agency. And this story was usually told with a tone of pride, and for most people, it was linked with a sense of greater well-being. The story of survival led a lot of people to take on advocate or mentor roles, whether that was sort of mentoring at their workplace, whether that was kind of looking after peers a little bit through support groups, or whether that was more formal kind of advocacy. But that seemed to be quite a common path. And these advocate and mentor type roles became narrative resources in themselves, shaping further stories about being a person who helps other people. And most people described improved well-being while talking about being a survivor or protecting other people. However, for a few people, their stories of survival and of protecting others didn't quite overcome their story of being undeserving of help. So the impact on their overall well-being was a bit less clear. Another theme that came up a lot was ADHD and trauma being intertwined yet distinct. So when talking about well-being, stories about ADHD and trauma generally became very mishmashed, intertwined all the way through. However, language and tone often remained quite different. So typically ADHD was spoken about fondly, like a friend, whereas trauma was something that had happened or had been done to a person. And I'm just going to read this one quote out because I think it's a really nice example that verbalizes a lot of things that other people kind of alluded to. But this really kind of, I think, captured the essence of something that came up quite a lot. I feel like the ADHD we're holding hands, we're like friends, whereas I feel like the PTSD is like on my back, and I feel like it's that the ADHD is part of me, whereas the PTSD is because of something that happened that I haven't got control of. PTSD doesn't quite feel like a friend. He kind of feels like he's still grabbing my hair. People who were more able to distinguish between ADHD and trauma when talking about their well-being generally spoke with a higher sense of agency over their lives and commented on feeling more fulfilled. For most people, the recognition of ADHD or trauma and access to support that recognise both, these were all like puzzle pieces and all had a massive impact on well-being. But there was a sense that healing couldn't fully begin until all of the pieces were in place. A minority of participants didn't make any distinction between ADHD and trauma. These participants were typically the people that hadn't been able to access ADHD and trauma-informed care. And their stories had less of a distinction between past and present in terms of the way they spoke about themselves. And people had more difficulty recalling kind of what happened on their journey to support. Yeah, and less optimism about the future. And when describing well-being, these participants very much drew on the absence of support as a narrative resource, and their stories were very focused on being failed, rather than there being kind of the commentary on the distinction between ADHD and trauma that some other people reflected on. And then the last theme is regaining control with the right support. So everyone was at different points in their recovery from trauma. Um, Access to support from a professional who had appropriate knowledge of both ADHD and trauma consistently became a narrative resource. This typically shaped stories of being confident and capable and having control over the direction of their lives. This support, so ADHD and trauma-informed support, took many different forms. People spoke about individual therapy, counselling, coaching, couples therapy. It didn't really matter particularly what the exact kind of support was. It mattered that that the person they're speaking to understood and kind of meaningfully incorporated ADHD and trauma into the conversation, into the support being provided. When this happened, participants commented on drastic improvement in their well-being, being a completely different person, and reflected how things might have been very different without this support. People also spoke about being able to rebuild relationships with family, communicate better with their partner, or develop better working relationships with colleagues. What I've started to refer to as ADHD and trauma-informed care, so abbreviating that to ATIC. So ATIC in relation to mental health was only found in the private sector by people who had the resources to access that, or people that are able to access it through like workplace health insurance, PIP payments. Some people had financial support from parents, or some people were just about in the financial position to fund it themselves, but were struggling with it, taking out credit cards. It wasn't something they were affording comfortably. People did comment on the expense being difficult to manage, but feeling like it was just absolutely necessary. So like I said, a minority had never been able to access ATIC for their mental health despite trying. While most people had shared experiences of being dismissed or ignored by health services, these few people described being judged and shamed by healthcare professionals over many years with no eventual success. They'd been given a narrative of being too complex sometimes, or of not being unwell enough, or of support simply not being available. And this served to reinforce their existing stories of shame and blame. This narrative, so this kind of narrative result of support not being available, shaped really powerful stories of powerlessness and of nothing ever changing. So yeah, these stories of powerlessness and shame for the people that hadn't been able to access ATIC left, in some instances, their mental health worse than it was before they'd kind of been trying to pursue support. And they typically spoke with really kind of visceral anger and grief for the life that they could have had if they'd been helped. And yeah, repeated experiences of feeling worse after seeking support from the NHS had shaped a story for some people of the NHS actively causing harm. And that did place people then in a very tricky position where they were really struggling with the effects of trauma or PTSD in some instances, really kind of needing help, but then being fearful of seeking help because of sort of negative past experiences. So to summarise all of that in a few main findings, I would say people spent years feeling ashamed, misunderstood, because both ADHD and trauma were unrecognised, and they often led very isolated lives. Concerns were often dismissed as anxiety or depression, and people were often offered mental health support or medication that wasn't helpful. And a few became fearful of NHS services after repeated experiences of it not being helpful. Recognition of ADHD or trauma could be life-changing, but understanding alone wasn't enough. This was just one piece of the puzzle. Support groups or networks were powerful tools that supported identity repair and improved well-being, even if a puzzle piece was missing. They weren't a substitute, but they did help a lot. People who accessed ATIC, ADHD, trauma-informed care, told more hopeful stories about their lives, felt more connected to others, had a stronger sense of control. However, ATIC was only found in the private sector. And that's just to touch on that. I am mindful that this study was only 13 people, so that's not me saying that ADHD and trauma-informed care doesn't exist at all in the NHS. I'm sure there's plenty of examples of good practice out there, but just in this particular study with these people, it hadn't been found at all in the NHS. And people who could not access ATIC continued to struggle with their mental health. They often became isolated, struggled to work, felt powerless. And yeah, a few people did describe their experiences with the NHS as traumatising. So if we think about all of this in relation to identity and well-being, if we think about that, the theme of making sense of shame, so ADHD, the naming of ADHD or trauma could be considered to be a narrative resource that shaped new stories of acceptance and survival. So from a narrative identity perspective, then their meaning making, their sense making ability started to be repaired once ADHD and or trauma was named. And then in relation to the proud survivors and protectors theme, support groups, online forums, advocate roles all help to shape new stories of community. And from that narrative identity perspective, people's sense of communion, the quality and the quantity of their relationships, that began to be repaired. In the ADHD and trauma intertwined yet distinct theme, so access to ATIC seemed to give people a greater understanding of themselves, which shaped further stories of people having control over their lives. And from a narrative identity perspective, sense of agency being repaired there, where they're feeling like they've got more control over things. And then lastly, in the reclaiming control with the right support theme, people who had accessed ATIC reflected on improvements in their mental health, family relationships, friendships, working relationships. They described pride in themselves and their achievements and relief at being able to reclaim control over their lives. So from a narrative identity perspective, that's both agency and communion being repaired there. So just coming back to that graphic one more time, now that you've had all of the information about the themes, it might hopefully make a bit more sense. It might not. Still quite a lot going on, but the idea of this is to kind of capture that sense of journey. Everyone's stories were unique in their own way, but if I was to try and sort of merge everyone into one a little bit, this is the overarching kind of idea of a journey from poor well-being to better well-being, and this is kind of the route that people took. However, where ATIC wasn't available, people didn't quite get to like the higher levels of well-being that people that had been able to access ADHD and trauma-informed care did. So how do we support people with co-occurring ADHD and trauma? So yeah, something that came out of the findings, I think, was that signposting support groups is a very simple but potentially very effective thing that we could be doing. Um, yeah, the results regarding support groups and support networks aligned with existing research that found that a sense of belonging and communion was a key benefit of a group format for people with ADHD. Given the high co-occurrence of ADHD and PTSD, it seems to me quite possible that actually a lot of people that are attending ADHD support groups have also experienced trauma. So in effect, you're attending an ADHD and trauma support group in a way. And it's been shown that the social support provided by a group can be protective against effects of trauma. So yeah, that really highlighted that ADHD support networks may be providing multiple benefits, providing protection from the effects of trauma, being a narrative resource for stories of social acceptance and communion. So yeah, that kind of simple measure of signposting, might be actually really helpful. So yeah, just that regular kind of checking and updating of what's going on in your local area where you can signpost people to. It's just a no cost, nice little easy win. I wouldn't say a substitute, but it's helpful, I think. And trauma informed practice. Now, obviously, this isn't a new concept, but I think the findings did also highlight that for my participants anyway, that they weren't really experiencing trauma informed care in perhaps the way that we would hope. That's not in the way that would be in line with trauma informed practice guidance. So I think actually just reflecting within services around, are we actually being trauma informed, or are we just saying that we're being trauma informed? And really going back to that guidance and thinking about ways to better implement that. And it is kind of acknowledged within the evidence base that although this concept of trauma informed care has been around for a long time now, actually its implementation has been quite hit and miss, bit piecemeal, I think one study called it. And going back to trauma informed practice within ADHD assessment services, just the need for really thorough assessment of trauma, which services that are following the gold standard assessment tools will be doing already. In a previous study, I ran challenges with sort of quality of assessment often in right to choose or private services came up quite a lot, where the thorough assessment of trauma or mental health perhaps just wasn't happening. So therefore, really obvious kind of trauma related concerns or signposting to trauma support wasn't happening because it wasn't being assessed. So, yeah, this study suggested that ATIC, or ADHD and trauma-informed care for mental health concerns, was a key narrative resource that shaped stories high in agency and communion and influenced wellbeing in a positive way. But sadly, participants in this study found that ATIC for mental health concerns was only available in the private sector. So yeah, even when ADHD was recognised, trauma was recognised, actually, if people weren't able to access that ADHD and trauma-informed care, that final kind of piece of the puzzle remained missing. And often that meant that care wasn't helpful, or in some cases, it was actively harmful when this was missing. So yeah, when we're talking about ADHD and trauma-informed care, what do I mean by that? Um, so for participants in this study, professional background of the clinician didn't matter at all. And neither did the actual kind of support that was being provided. Like I said, people spoke about all different kinds of therapy or support or ADHD coaching. It really didn't matter. It was more that actually, but people, the person that was providing that support had that knowledge of ADHD, had the knowledge of trauma, was incorporating it into the conversation and in a meaningful kind of way rather than it being tokenistic. Um, yeah, and actually being able to pull apart ADHD and trauma. I'll come on to that in a little bit more, but someone having enough knowledge of both to be able to talk about both and help people separate it in their minds. So at the moment, national guidance for ADHD informed practice doesn't exist. There are lots of resources out there. That's not to say that, there isn't anything, but just in the same way that trauma-informed practice has kind of nationalised, standardised guidance, that doesn't exist for ADHD. But there have been multiple calls in the literature for something, along these lines, calling for standardised guidance, better training for professionals, more consistent adaptations for people with ADHD in line with the Equality Act. But yet, so far, there's nothing really out there. And NICE guidance often focuses on does focus on the treatment and management of ADHD, but there isn't really any acknowledgement of the harm that can be caused inadvertently when ADHD informed care isn't there. So moving on to my next kind of subject, just as a little reframe for you, if you view ADHD as part of identity rather than an illness, does this change how you would approach your client work? So honouring neurodiversity. So very much in line with people wanting sort of this ADHD and trauma-informed care. Existing research has found that a needs-led holistic approach to healthcare is essential when providing healthcare to people with ADHD. And yeah, kind of everyone in the study was aligned with this kind of viewpoint. So in addition to echoing calls for holistic support, this study also found actually the labels of ADHD and trauma had some utility in helping people distinguish between the two, and that might have positive implications for well-being. Yeah, people commented on actually being able to understand what was ADHD, what was trauma, where they needed to challenge themselves, where they needed to accommodate themselves. That was something people found really helpful. Yeah, and going back to that quote I read out, people started to really then view ADHD and PTSD, or ADHD and trauma, very separately, with ADHD being more of a friend, something that they make accommodations for. But yeah, PTSD trauma, something where they can challenge themselves, where that's something more to be overcome. So bearing in mind that actually these participants found it helpful to be able to distinguish between ADHD and trauma, this kind of suggests or supports existing research that suggests needs-led approaches were most effective when an individual's neurodiversity was honoured while their mental health concerns were being treated. And this suggests it perhaps might be helpful for professionals to allow their client to guide the use of language in relation to neurodiversity, even when this language is diagnostically focused. And this might be something that most of professionals are doing anyway, as kind of a common sense thing. But like I alluded to earlier, there is this kind of polarization within the evidence base around how to conceptualize ADHD. And to some extent, I think in healthcare as well, certainly in politics and the media, there's a lot of chatter about ADHD at the moment. And I think that can filter its way down into how people support, whether that's in the therapy room, whether that's just sort of in health services more broadly. So I think, yeah, it is important to reflect on actually how we use the labels, and actually the label isn't necessarily a negative thing. It's more how your client perceives it, and if the label has utility for a client, then be guided by that and explore what that means to them. And yeah, this is very much in line with the movement towards identity first language within the ADHD and autistic communities. So yeah, like I was saying, some research has very much cautioned against viewing neurodevelopmental conditions through a diagnostic lens, suggesting this might risk reducing a client to a label or associated diagnostic criteria. Some literature raises concerns about, all diagnostic labels, not just ADHD and autism, but over pathologizing normal behavior. I've seen a lot of discourse in the literature around illness identity in relation to ADHD and autism, suggesting that fusion with a diagnosis might be associated with a lower quality of life. However, there's also, as with most of the conversation about ADHD and autism, there's always another side of it. Critical disability identity theory would position disability as an important and positive part of identity. And that very much aligns with the position taken by ADHD and autistic communities that would use that identity first language, consider ADHD and autism to be part of identity. But yeah, there is very much that polarization there, which I think has the potential to be really confusing for clinicians, for clients, when we're not too sure how to conceptualize, how to support, because yeah, the evidence base is so divided. But the good news with that is that we don't really have to pick a side, in my opinion. It's all about taking that kind of nuanced approach. If we use these labels to just explore attached meaning, associated thoughts, feelings, and behaviours, we can find a bit of a middle ground there. And I think at a time where neurodevelopmental conditions like ADHD and autism are the source of a lot of discussion within the media, politics, healthcare services, it's probably particularly important for us to be led by clients' needs and language preferences rather than by sort of political or social discourse. And just a few reflections of my own on this. I find myself, when I talk about the polarized evidence base and I guess the kind of conflict there, I very much find that I have that conflict within myself, because on the one side I'm someone that lives with ADHD, but also I'm like a trainee psychologist that would often lean away from using diagnostic labels. So yeah, I have a lot of experience of trying to sit with this conflict and make sense of it. So my own reflections are that in this study, people found the diagnosis of ADHD allowed them to tell more compassionate, accepting stories about themselves. Failure was reframed as difference. Repeated experiences of rejection started to be replaced by new stories of community. And most importantly, these new stories serve people and enable greater well-being. So in the absence of certainty in the literature, hearing these stories has helped me to kind of navigate my own conflict shape a pragmatic approach to my own clinical practice. Ultimately, I think the stories people tell themselves about their diagnosis are more important than the diagnosis itself. I think it's important to understand what stories with people with ADHD or autism tell about themselves, whether these stories serve them, or if they don't serve wellbeing, there might be scope for intervention there. But ultimately, I don't think I'm going to be able to understand these stories without asking about or using the diagnostic label. That's kind of the place I've got to with it. So overall, two main conclusions and then a bit of an idea for future research. So I think ATIC, ADHD trauma informed care, particularly helpful in primary care and mental health services. At the moment, in the absence of kind of standardised ATIC guidance, I think just additional training, awareness of both ADHD and trauma, really, really helpful for people. And just a recognition that actually you don't have to be an ADHD or autism expert to be able to practice in an ADHD or autism informed way. You just have to be willing to use the language that your client's using and be curious and find out what it means to them. You don't have to be up to date with all the latest literature because, my God, there is a lot out there. Also, it might be helpful for primary and secondary care services to signpost to ADHD support groups and networks. Like I said, that might be protective against the effects of trauma. It also might be helping with that identity repair, so helpful in lots of different ways. And then in terms of future research, I've proposed a project that hopefully might get picked up by next generation of trainees around generating a framework for ADHD and trauma-informed care. I'm very mindful that this existing study was majority female, majority white, and also didn't really involve people from sort of inclusion health backgrounds. So, we got a sample of people that had the time, the energy, the inclination to take part in research, that had access to the internet, that kind of thing. It's a sort of a very specific sample of people. So in future research involving a broader range of people would be really important, and also incorporating the voices of autistic adults, because over half the people in the sample either had diagnoses or identified as being autistic, and just in the literature we know that there's so much crossover and comorbidity with ADHD and autism. It would, to me, feel a bit silly to make a framework for ADHD and trauma informed care without it sort of being autism informed as well. So that brings me to the end of my presentation. So yeah, I have got a questionnaire. It's very much around measuring the impact of this research. So me getting a feel for who was in the audience today, who's interested in it, essentially. But also and help me understand who else might be interested, more to the point, who else I can potentially target that might want to hear about this. Also, in terms of that future research project I mentioned, identifying people that might be interested in taking part in that, whether that's on the professional side of things or whether you're someone with lived experience, both would be involved ideally in the project that I'm thinking about. So within that form, there's a space for you to sort of leave your contact details if you want to be contacted at some point in the future if we do start developing a framework for ATIC.